All right, so now we'll go over pituitary. So pituitary drugs are natural or synthetic hormones that mimic the hormones that are produced by our pituitary glands. There are two groups that affect either the anterior or the posterior pituitary. The first we're going to talk about are the posterior, which are used to regulate fluid volume. So these involve fluid balance and blood pressure. Desmopressin is or you might also see that abbreviated as DDAVP, and that is the drug of choice for patients who have neurogenic DI or diabetes insipidus, which is an excessive loss of urine caused by a brain lesion, a head injury, or an injury that interferes with antidiuretic hormone synthesis or released. It can be administered intranasally, oral, sublingual, or sub-Q or IV. It has a long duration and has few adverse effects. Vasopressin is short-term, and it is used to elevate blood pressure in patients with hypotension. High doses can actually be given during pulseless cardiac arrest instead of epinephrine. Hypersensitivity is the biggest risk with given DDAVP or desmopressin and vasopressin, and that looks like a seizure, anaphylaxis, anxiety, hyponatremia, water intoxication, headache, or transient edema. So we want to monitor for hypertension and water intoxication, high blood pressure, or hypotension. Make sure we're taking daily weights. And then they could be potentially given different morning and evening doses based on the patient's fluid status. If we're giving it nasally, we want to make sure that their nasal passage is clear, and we're monitoring for congestion or infection. If we're using it via injection, we want to make sure that we're rotating the sites, and that they're drinking only enough water to satisfy their thirst, that they're monitoring their eyes and nose, their serum and urine osmolality, and the urine and specific gravity, as well as electrolytes. Okay, so those are specific to the drug. And then we'll talk about the indications. So the desmopressin and vasopressin is what I've talked about so far, right? And that can be used to treat diabetes insipidus. Diabetes insipidus is when they are missing antidiuretic hormone. So they have a massive diuresis of dilute urine, and they have a severe dehydration with high serum osmolality. Okay? So we give them desmopressin or vasopressin to suppress that urine. And vasopressin, you can think of that as it presses the vasos, so it presses the vein, which is going to increase the blood pressure, okay? The opposite of that is SIADH, which is syndrome of inappropriate antidiuretic hormone. And this is excess ADH. So the body is going to retain massive amounts of water, which leads to dilutional hyponatremia and seizure risk. So we're going to put them on fluid restriction, give them loop diuretics like Lasix, and monitor their sodium levels. And then we may give those hypertonic solutions. Okay? So this is just another picture of this. Remember that the pressors, the vasopressin and desmopressin, are pressing that fluid back into the body. So they're going to decrease the urine output and increase blood volume. So because of that, it can push a patient into fluid overload. So we're monitoring for pounding headache, which could be a sign of water intoxication. Okay, and then for the SIADH, like I said, we're putting them on the fluid restrictions and administering that hypertonic saline if we have to. And do y'all remember what hypertonic saline is? Anywhere from 3 to 7% saline, right? So am I giving them normal saline? No. Am I giving them lactated ringers? No. Am I giving them half normal saline? No. We're giving them lots of saline, okay? All right, so next we're going to talk about the anterior pituitary hormones. One of those is the growth hormone. So this isn't given orally. This is given in pediatrics who have growth failure due to inadequate growth hormone. Important to know that if this is given with androgens or amphetamines, so if the child has like ADHD, that could be a concern because it can promote epiphyseal plate closure. So that is one of the biggest considerations with administering growth hormone. It's given to kids while they're growing, but it has to be stopped prior to their growth plate closing, okay? Also, if this is given with corticosteroids, it can inhibit growth, the growth-promoting action of somatropin. Know that these people can have body image issues. It can be given sub-Q or IM. A memory aid for somatropin to help you remember why you give it is Summer Gets a Trophy for growing. We want to monitor for hyperglycemia and pancreatitis. Biggest thing to remember with this is we're not giving it once their growth plate closes. If they have too much growth hormone, or we've given them too much, then we're going to give them octreotide, which suppresses that growth hormone release. Some side effects of that are GI issues, gallstones, and bradycardia. And this is just another picture showing that. All right, and then this is just a little memory aid kind of recapping on some of the things you're going to monitor for some of the more commonly given medications. So for metformin, we're monitoring their kidney function, their BUN, and their creatinine, as well as their liver function. Remember that we're holding for what? Contrast dye. Good job. Corticosteroids, we're going to monitor their glucose, their white blood cell count. Why are we monitoring glucose? Because it can cause excess, like hyperglycemia. Why are we monitoring white blood cell count? Because it can cause immunosuppression. Potassium, it can cause hypokalemia, so they might need to take potassium. And then it can cause osteoporosis, so they may need to take calcium. Levothyroxine, we're monitoring that TSH, T3, and T4. So remember, if they have hypothyroidism and they need to take levothyroxine, what would their T3 and T4 levels be, high or low? They have hypothyroid. Okay, and before I tell you the answer to that, what will their TSH levels be? So their thyroid stimulating hormone is going to be high, right? And their thyroid hormones are going to be low, which is why we're giving them synthetic replacement. If it's hyper, we would be given different medications, but their thyroid stimulating hormone is going to be low, and their T3 and T4 will be high. For desmopressin, we're monitoring their sodium, their specific gravity, and osmolality. And we're looking for that dilutional hyponatremia. Also want to measure blood pressure for sure, as well as what? This has to do with fluid. Eyes and nose, right? And then insulin, we're monitoring glucose and potassium because of that close relationship. We're also monitoring A1C, right, to give us a bigger picture. And then know that they are at risk for hypoglycemia and hypokalemia. Okay, so nutrition does play a big role in these as well. So we want to increase fluids with diabetes insipidus. We want to hold them for SIADH. Increase for hypothyroidism to prevent the constipation. And then we're also restricting for Cushing's because we want to prevent that overload. For sodium, we're increasing for Addison's, and we're restricting for Cushing's and SIADH. Calcium and vitamin D, we're increasing for Cushing's as well as that long-term steroid use. If a person has something like asthma or lupus, or they have an organ transplant where they're on this for chronic, there's the word, immunosuppression. Because that risk for osteoporosis, we're increasing calories for hyperthyroidism because they have that increased metabolism, and we're increasing fiber and decreasing calories for hypothyroidism because of that constipation. All right, so here's just a recap of some things to remember. We're going to taper the steroids, make sure that we remember that they might need increased steroids during time of stress if they're on them chronically. We're never just abruptly stopping corticosteroids. We're going to not give contrast with metformin. Always, 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 in any situation, including an insulin pump, but with anything, a blood pressure, a EKG, a lab result, I'm going to treat my patient before I'm treating a machine or a result, right? That's a helpful tool. I'm glad that I have it, but my patient's symptoms are what and my patient in my face is what I'm treating. Remember that for type 1 diabetes, insulin is lifelong, and for hypothyroidism, levothyroxine is lifelong. Also, remember that if a person has hyperthyroidism and they receive radioactive iodine to shrink their thyroid, or they have surgical removal, that then they're going to have hypothyroid and then they're going to need replacement, okay? And then remember that if our patient isn't eating, we aren't going to give them short or rapid acting insulin because they need food, right? So we need to make sure that there is food available to them. If they're throwing up, are we giving them insulin? No. If they are going to surgery and therefore not eating, are we giving them rapid insulin? No. Unless their their blood sugar is crazy high, then we're not doing that, okay? What am I giving them if their blood sugar is very low? If they are hypoglycemic, what am I giving them? Sugar, right? So I'm giving 15 grams of carbs. I'm giving potentially glucagon or 50% dextrose. Never stopping corticosteroids abruptly because it can cause Addisonian crisis. I'm not mixing the long-term insulins with themselves or anything. I'm not giving rapid-acting insulin when I don't have a tray. And I'm never giving metformin within 48 hours of IV contrast stop. All right, and that wraps this up.